So my topic is management of first-time shoulder dislocation, and it's anterior, of course. I come from Acıbadem University in Istanbul, and these are my disclosures. So the dislocation may be seen almost at any age, starting from the adolescence, but we will cover the young adult, mostly the athletes. I'll be talking about it. And natural history is important in these patient groups, return to play, when to return, and then will it recur or not? And the performance is important. This is often neglected in these literature. Of course, the patient may not have a dislocation, but not performing well. And how many games and practices he or she is going to miss. So do we have to operate on it? And there are good results in the literature. Conservative success may be up to 80% in high school athletes, and a full season, the first season, without recurrence. And in another study, 90% completed the initial season, and missing an average of 10 days. But in the off-season, more than 50% had to have surgery. So these are good to have to approach initially. But nothing ruins a good treatment more than a long-term follow-up. If you look at this study, more than 50% required stabilization. And patients aged 12 to 22, they had 38%, additional 12 continued to have symptoms of instability. And if you don't do anything, only 20% become stable after 15, 25 years later. So the degree and type of pathology dictates the type of treatment. Humeral avulsion of the glenohumeral ligament, this is often missed. Rotator cuff tears, glenoid and or humeral bone loss. It leads to major biomechanical disturbances. Non-operative treatment may be preferred in less active patients, older patients. So should we operate or not? Most people are preferring surgical intervention recently, and we know there are multiple level 1 RCTs show that there's increased recurrence with non-op treatment. There are improved patient-reported outcomes, event-free survival, significantly better return to pre-injury activity levels, especially in the young athletes. We have to draw this line. The male athletes, the younger, the type of sport, overhead athletes have to be understood. Age is consistently important in many studies. Why more in the young? The young that has unconstrained activities, they inherently move, they naturally move. They don't think whether they should move or not, they move. And also the histological ultrastructure of the capsule and the ligament. So we can say young, male, collision athlete and or overhead athletes are the best candidates for immediate surgical stabilization for maximum functional outcomes and prevent instability. So when do we do it? Do we do it immediately or delayed? I put this picture. This is how I would treat a rather lax shoulder, the standard anterior, posterior portals, and I also use posterior inferior portal, of course taking care at the axillary nerve, and the Wilmington portal for the slap if necessary. Decision is influenced by a host of factors. When is the time of the season? If you are towards the end, you might do it immediately because you're already going to lose 2 weeks, 3 weeks time. And the eligibility, the parents are the most important in the young, and they all think that their child is going to be a Cristiano Ronaldo, or depending on the sport, or Nadal. How the patient will proceed, we should try to foresee. And most importantly, the coach will tell you. That's who I listen to the most. Behind the parents, I try to listen and make a decision. So we have to base our decision on risk of recurrence and return to play, when to allow the patient to play. So this was a prospective multi-center study on college players. Return to play in the subsequent season was 90% with stabilization compared to 50% stabilization. So we can wait. But delay may not be safe. 40% recurrence within the season in one study, and 73% within the season in this other study. When there's delay and allow the patient to play, there are higher anatomic injuries and higher postoperative failure rate if you allow the patient to wait. So when you synthesize the literature, decision is multifactorial. You have to understand the functional demand, the gender, age, anatomic risk factors, sport-specific circumstances. Increasing evidence favors immediate stabilization, especially in these patients. So once you make the decision, you have to restore the native anatomy, maximize function, and minimize recurrence. So these are the typical pathologies that Dr. Grigoris showed us. I will not go in detail. Labrum is the primary injury in a simple first-time dislocation, but there may be capsular stretching with repeated dislocations. Bankart lesion is the primary one, but bony Bankart and other hidden lesions like Albsa, Hagel, Glad lesions are important, and we have to find them out. As pointed out, bone loss is very important. We have to decide whether it's on track, off track. This is a very important concept that has come into our lives, and that's how we proceed and decide what to do. Bolow's patient activity level ICE score is the one that I use the most, and I try to foresee what's coming. And the first dislocation, things are not stretched, so it's good candidates for successful arthroscopic repair. So this is a very typical of what I encountered and what you may encounter. This was a 22-year-old male active basketball player, traumatic dominant shoulder dislocation, did not choose surgery. So he went on to play for 10 months. And he felt good after each month. He felt better and better. And then he comes back after 10 months, and this was on track. So I let it go. 10 months later, he comes with a second dislocation, and this was the case. He had a second Hill-Sachs lesion, apart from the first one, with an intact cartilage in between. So now, with the second lesion, so it's to the right at the initial Hill-Sachs, and we have a big major cartilage defect. Now he's off track. So the anatomic standings have changed. Thank you for listening.